Hello everybody, I am Dr. Sathish. I am a consultant diabetologist practicing in Bangalore, Karnataka, India. Well, today I am here to talk about the FNAC and thyroid gland. The thyroid nodules are common clinical findings and have a reported prevalence of 4 to 7% in adult population. However, fewer than 5% of adult thyroid nodules are malignant, and the vast majority is non-neoplastic lesions or benign neoplasms. However, the distinction of these benign lesions from malignant nodules cannot be based reliably on the clinical presentation alone. FNAC of the thyroid gland is now a well-established first-line diagnostic test for the evaluation of diffuse thyroid lesions as well as thyroid nodules, with the main purpose of confirming benign lesions and thereby reducing unnecessary surgery. Its use in recent years has resulted in a significant decrease in the number of surgeries being performed, while increasing the yield of malignant lesions of patients who have undergone surgery. Due to its simplicity, low cost, and absence of major complications, it is the initial investigation in the management of thyroid disease. Different imaging techniques are now used for diagnosis of thyroid nodules like radionucleotide scanning, high-resolution ultrasonography, etc. However, FNAC is still regarded as a single most accurate and cost-effective procedure, particularly if ultrasound is used as a guide for better sample collection, especially for cystic lesions. FNAC is considered as a gold standard in the investigation of thyroid nodules. Studies have suggested a high sensitivity and specificity for predicting thyroid malignancies, averaging 83% and 92% respectively. Nevertheless, like any other test, FNAC has its limitations and diagnostic pitfalls. These limitations include false negative and false positive results, and a proportion of FNA results that are not obviously benign or malignant and fall into the indeterminate and or suspicious group. The reported pitfalls are those related to specimen adequacy, sampling techniques, the skill of physician performing the aspiration, the experience of the pathologist interpreting the aspirate, and the overlapping cytological features between some benign and malignant thyroid lesions. Why a thyroid FNAC is done? Well, to put it simply, to differentiate between a benign and a malignant nodule. Indications for FNAC, that is clinical thyroid nodules more than 1 cm, hypofunctioning nodule, history of neck irradiation, family history of cancer, FMTC associated with red proto-oncogene mutation, age and sex. History and physical examination lack the sensitivity and specificity sufficient for diagnosing a thyroid cancer. Thyroid nodules are very frequent, and it is estimated that 4 to 7% of adults have palpable enlargement of thyroid and 10 times more have impalpable nodules. Thyroid nodules are more frequent among females, elderly people. History of irradiation to head and neck, and a diet containing high amount of goitrogens. Most of the thyroid nodules are benign, and fewer than 5% of them are actually malignant. What is the role of FNA biopsy? FNA is the most accurate and cost-effective method for evaluating thyroid nodules. Retrospective studies have reported lower rates of both non-diagnostic and false negative cytology specimens from FNA procedures performed via US guidance compared to palpation. Therefore, for nodules with higher likelihood of either a non-diagnostic cytology or sampling error that is difficult to palpate, or posteriorly located nodules, ultrasound guided FNA is preferred. If the diagnostic ultrasound confirms the presence of predominantly solid nodule corresponding what is palpated, the FNAC results can be assessed in the following way, that is Thigh 1 non-diagnostic, Thigh 2 non-neoplastic or negative, Thigh 3 all follicular lesions, Thigh 4 suspicious of malignancy, Thigh 5 diagnostic of malignancy. Various sonographic characteristics of thyroid nodule also have been taken into consideration while suspecting malignancy. These include nodule hypoechogenicity compared to normal thyroid parenchyma, increased intranodular vascularity, irregular infiltrative margins, the presence of microcalcifications, an absence of a halo, and a shape taller than the width measured in the transverse dimension. These things should be used in conjunction with FNAC while arriving at a diagnosis. Where else an ultrasound can be used to guide FNAC? In a multinodular consistency on examination, Hashimoto's thyroiditis, difficult neck examination, surveillance in patient with known nodules or thyroid cancer, growth in nodule with previously benign FNA cytology. So how to do an FNAC? The patient is made to lie down and the neck is exposed. The area around the neck is cleaned. If a patient is particularly concerned or nervous, a topical anesthetic preparation may be applied. Otherwise, it is done without an anesthesia. Once the patient is ready, a small fine gauge needle is inserted into the nodule, that is usually a 25 gauge of 1.5 inch needle. The patient holds his breath while the needle is rocked gently to obtain as much tissue as possible. The reason for holding breath is to minimize movement of the structures in the neck. The needle is then withdrawn and the pressure is applied over the thyroid area to minimize bleeding. This procedure is usually repeated 4 to 6 times to ensure that an adequate amount of tissue has been collected. After the procedure, pressure is applied over the neck area for 5 to 10 minutes to assume that the bleeding has stopped. The pressure also helps to reduce any swelling that may occur. The entire procedure usually takes less than 20 minutes. Maximum 3 punctures per nodule should be done. The risks of needle aspiration biopsy of the thyroid include bleeding, infection, and cyst formation, but these complications are exceedingly rare. So FNA has proven to be accurate in the triage of patients with thyroid nodules. However, it remains a tool that must be integrated with other diagnostic procedures such as ultrasonographic and scintigraphic examination of the thyroid gland. It should be kept in mind that only a multidisciplinary approach can ensure the best results, and that diagnostic accuracy with thyroid borderline lesions cannot rely solely on the cytologic criteria. In addition, morphologic criteria are not only hindered by poor reproducibility but also are affected by quantitative and qualitative variables that are strongly dependent on the expertise of the operator performing the FNA procedure. Thank you.